in Vermont while wearing Palestinian kufiyyas like this and while speaking in Arabic. Hisham, 20 years old, studied mathematics and archaeology at Brown University. Kinan, 20 years old, was a pre-med student at Haverford College. And Tahsin, 20 years old, also studied mathematics and IT at Trinity College. All are alumni of my high school in Ramallah. And depending on what news outlet you follow, you might have come across articles or statements that say that there's not enough evidence yet to support this being a hate crime. But we know the climate that we live in. Wadi', the 6-year-old who was stabbed to death in Chicago, and his mother also know the climate that we live in. All of us who wear our kufiyyas and walk to try to represent and be there in solidarity with our Palestinian families and friends who have received verbal abuse or looks in the street know the climate. This is the cost. It's costly and it's painful. And this is the outcome of all rampant, unchecked, and unrestrained anti-Palestinian rhetoric that we are living. The constant dehumanization and the dehumanizing narrative of us, our clothes, and our language. And we've been using this word more often lately, dehumanization. What does that mean? And what does it lead to? And where does it come from? Dehumanization is to deprive somebody not only of their human qualities, but of their dignity and of their personality. And what starts happening is Palestinians start passively dying instead of being actively killed, and start being seen as numbers instead of people with stories like all of us. And this devaluation that is constantly regurgitated media in the most seamless ways, and that is omnipresent in all the news outlets that cover Palestinians, lead to something that is very dangerous, the inability to sympathize, because you can't draw parallels and you can't find an overlap. And what that leads to is that we have to add layers of humanity and accomplishment to relate to the foreign audience that hears us, i.e., what I have just done, talking about these students' accomplishments and what they study and what they major in order to create an element of relevance. But what does that also lead to? It makes all the other Palestinians lose that relevance. And we hence lose our ability to find that sympathy to all the other Palestinians that are losing their lives. When sympathy becomes contingent on Western relevance, it takes it away from all the other Palestinians, and it makes it truly bankrupt. With that, I'll try, we should all try to stay cautious of our own language and stay conscious of the narratives that we hear. And with that, I'll try to segue into today's topic at hand. It's difficult generally, and for us healthcare workers or people in healthcare specifically, to relate and hence sympathize with the healthcare crisis that is happening in Gaza, simply because we don't see it. But the first step to sympathize is to be informed. And for that reason, I thank you, Noor, and I thank our speakers today for keeping us informed and getting us one step closer to truly be able to sympathize. Thank you.
Thank you, Bess. And what I didn't say when introducing you, not to you were talking about how we need to sort of beg for empathy and humanity, and we need to say that, Palestinians can be doctors and they can be lawyers. But I do want to say that you are a resident internal medicine in Tufts. And so thank you so much for being here. Shukran, Bess. Our next speaker is Dr. Ali Sabatin, and he became the first certified infectious disease specialist in Palestine in 2013. Since 2014, he has been the head of the infectious disease department at Augusta Victoria Hospital in Jerusalem. At the national level, Dr. Svettin is a major promoter of the rational use of antibiotics in Palestine. He was selected as a technical advisor for Palestine's National Quality Improvement Collaborative through the ASSIST project funded by US aid, achieving the main aim of the project, which was reducing hospital-acquired infection in Palestine by 20% in 2017 to 2018. He is now the director of the national initiative of an antimicrobial stewardship program among 30 hospitals. Thank you, Dr. Svettin. The mic is yours.
Thank you so much. Hello, everybody. Thank you for having me here and giving me the opportunity to talk about very important and sensitive for all of us topic about the situation in Gaza and to look at from the scientific point of view. I would like to share something, if you could please make me host. So I'm going to talk about the infectious disease in Gaza nowadays during the war, but before that, I think the infectious disease doctors and also infectious disease interesting people, they have to take an overview for the problem before starting to deal with this problem. For that, I would like to give you some brief about the situation in Gaza before the 7th of October, let's say, before this war, because it is very useful for you. Do you see this presentation?
Yes, we can, but could you put it in presenter mode?
Yeah. That's okay now?
Yes.
Okay. What about my language? It's okay, clear for you?
Yeah, absolutely.
Okay, good. So, Sector Gaza, I think everybody know a lot about Gaza Strip, but I would like to emphasize that it is the most crowded area in the world, and with about 2.5 million Palestinians, they are living in 365 kilometers square. That's mean they are the area is crowded a lot, and that means there is an environment for infectious disease to be spread there. So this is before the war. The Gaza Strip has been blockaded for 16 years. You can imagine that. What does that mean? But with all limitation of the products going in or going out from the Gaza Strip, but the good things, they have all the time good vaccination program, preventive medicine, and also in the primary health care, they are good. But due to this blockade, they have poor and limited resources for affected the infection prevention and control measures. Why I'm saying that? Because their baseline with infection prevention and control measures is poor due to the resources, limited resources, and ability to improve themselves was very difficult and challengeable. Also, the control of use of antibiotic was poor. So they had from the beginning two main problems with infection prevention control and abuse of antibiotics. The antibiotic abuse, there was at all levels of use of antibiotics. And we had seen a lot of multi-drug resistant bacteria. I'm talking about carbapenems resistant Enterobacteriales, Acinetobacter baumannii, VRE, and third generation cephalosporin resistant gram-negative bacteria. That's all with the baseline, and even before the start of this last attack. It's worth to mention that if the disease would be happen, there needs three things connected together: the agent, the causative agent, the host, the patient here, and also the environment. And that's give us that will talk in this presentation about all these three things, and we'll move in the slides about all these things to talk about infectious disease in Gaza. Important also, and you all know the cycle of transmission of disease, and it's important that the agents should go through all these cycles to reach the susceptible host, who is here the patient. So in order to keep our patients from agent to receive this disease or to develop this disease, we have to break the chain of disease, by using the environment, cleaning, hand hygiene, personal protective equipment, all these things, between brackets, the infection prevention measures. So this is important to prevent infection. What about the situation in Gaza? This is the situation in Gaza in the hospitals. You can imagine and you can look, I'm talking just scientific, not political, but this is now Gaza patients, they are receiving their medical services in some of working hospital, because a lot of hospital out of services now due to lack of water, there is no water, there is no electricity, and there is no places, in addition to the damage that were done by the Israel army in the hospital. So the infection prevention control measures, by this overview, you can see this. There is no absolute measures, and there is no ability to do that. There is no hand hygiene, there is no sanitation that could be done, and you can see the blood over all the floor here. The patients are receiving their medical service, if they are able to receive that, in the floor without beds, and also a lot of people around them. So from this picture, we can imagine there is no infection control now, and if there is any multi-drug resistant or possibility of disease to be spread, it's the environment to be that. This is crowdiness also, not just in the hospitals, is the corridor of one of the hospitals, and also there where is the patients living now. They are replacement, displacement for those people to the between brackets safe areas. But we know all that those schools that related to the United Nations also, they received attack also. Okay, there are no essential things to prevent development and spread of infection, as I mentioned, because there is no ability to do that. Also, let's talk about other things, factors that would help in developing and emerging the infectious disease in Gaza during this war. I'm writing here contaminated food and water, but I'm not sure there is any food even or water now they have. But if they have some food or some water, they are absolutely contaminated, and there is no ability to take healthy food and water for drinking and for eating. Also crowding, and we will talk about that. Lack of sanitation, and this obvious from the pictures that I showed before. Wounds and burns infection with multi-drug resistance is a huge problem, and hopefully we will listen about that also from the next presentation. Lack of vaccination nowadays, I'm talking about tetanus, for example, and possibility to develop this serious infections. Pollution, services, sewage problem, and infrastructure, keeping in mind also the infrastructure damaged completely at Gaza Strip. Also, there is no electricity to move all these issues outside and to the track that they should go. Let's talk about one of the first one is the food and water. Food should be presented and as we see here in the picture, clean and with a environment healthy, should be as like that to protect from any possible food poisoning related to the infections. So if there is a problem with preparation or storage, in inadequate cooling, inadequate reheating, or undercooking, inadequate thawing, all these factors lead to the development of food poisoning. And what we are seeing in the Gaza, it's just you can imagine the process of cooking and distributing the food for the people who are hungry and waiting to take their meal as well. Water also, it is difficult to find it, and if they find it, it will be a lot of time to take some of water for drinking, or there will not be enough for cleaning, for example. So it is a major problem with water and water cleaning and sanitation. Let's talk about the diseases or infectious diseases that could develop due to the food and water problems. If we're talking about food, we can divide that due to the agent itself or the bacteria itself, or due to intoxication that releases from this agent, from this bacteria as staph, for example. So the diarrhea could be, or food poisoning that can manifest as diarrhea and GI symptoms, fever, abdominal cramp, abdominal pain, and vomiting. That could be done by salmonella, shigella, hepatitis A, typhoid, cholera, polio, giardia, E. coli, and amoebiasis. But polio, for example, I don't think this is the problem and will not be a problem, because, as I mentioned before, the vaccination program that they have and had before, it's a strong one, and they are giving IPV, OPV that will prevent, I think, an outbreak in this area. But still, we have to take consideration. That's in consideration. What about crowding? Yeah, this is a movement from area to area with very huge number of people. With also, they are sleeping in the schools of that related to the United Nations. For example, each at least of the school, they have 11 or 12,000 people living in small area in this, and that crowdiness will give you an answer what possible to develop all these things nowadays, upper respiratory tract and lower tract infections, because the route of transmission will be easier with this a lot of people and crowding. And that will also affect skin infection, contact as a route of transmission, skin infection, and they are suffering from infection, hepatitis, scabies, and particular slices and nets. So also will affect gastroenteritis and hepatitis A. By the way, I will present in the last slide the actual numbers, not actual, but then statistics and numbers from Gaza surveillance regarding these infectious diseases. But I have also to mention the problem with wounds and burns infection with multi-drug resistance. Here a problem. There is lack of infection prevention control measures. I'm talking about hand hygiene, lack about materials for hand hygiene, lack of PPEs, lack of isolation process, of course, and lack of antibiotics. Several antibiotics they don't have any medication even. So the problem, the result will be wound infection with multi-drug resistance, and the result sepsis, septic shock, and even death. And we are starting to listen about this. Even CRE, cholesterol resistant, and bugs, they are super bugs resistant to all antibiotics, and nothing can stop with those microorganisms. Pollution also that will affect the people with diabetes and immunocompromised patients in developing invasive fungal infection, and also this will be a problem, and we'll see all these diseases, invasive fungal infection after and now during this attack of war. Corpses. I'm talking about blood-borne viruses and also gastrointestinal manifestation of infections. Here I'm talking about hepatitis B and C and HIV. Fortunately, HIV we don't have it so much, even if we have in Gaza Strip. But hepatitis C, they have hepatitis C. Hepatitis B, due to vaccination program, they don't have hepatitis B, but hepatitis C they have, and I think it will spread more. Gastrointestinal factors, cholera, E. coli, all hepatitis A, rotavirus, diarrhea, salmonellosis, shigellosis, and typhoid also could be manifest as gastrointestinal infection. In addition to tuberculosis, but also we low risk country with tuberculosis. Sewage also, I have to mention that because it's an problem there due to, as I mentioned, damage of all possibility to go through the track, and also there is no electricity. That also can be manifest with gastrointestinal diarrhea, with other diseases related to the contaminated water. That will be also the sewage will contaminated the water if they will have it. Poliomyelitis, I put it in the green because I don't think this is one of the major problem there. This is the statistics, and I could receive it from the inside of the Gaza. It's from 24 October to 27th of November, but they are not involving the north of North Gaza. The surveillance done just in south and center due to the political issue and dangers to reach the north area. So we are talking about very big numbers, and this is not the actual number, but there are registered 106,642 upper respiratory tract infections, which is involving H1N1 and also COVID and other upper respiratory tract infection. Most of them among the pediatric patient, diarrheal disease cases. Here, there is no identification for positive agent. There's just surveillance one for diarrhea. They are divided to bloody diarrhea and non-bloody diarrhea, and we have 74 almost cases.
Dr. Sbattin, sorry, I hate to interrupt, but we want to leave enough time for our next speakers, but we would love it if you could send us the slides so I could share them with our attendees, and I'm sure you're going to have a lot of questions in the Q&A,
okay.
So please stick with us, yeah. Thank you.
I will stop the sharing.
Thank you. Our next speaker is Dr. Anna Farah, and I'm going to spotlight her. Dr. Anna Farah got her medical degree from Karolinska Institute in Sweden in 1996 and completed a diploma in tropical medicine in France in 1995. She also completed her residency in infectious disease in 2006 in Stockholm. Dr. Farah has taken a keen interest in world health. She has been to Zambia on a minor field project in 1996. She has worked abroad on several occasions, mainly in Myanmar, in HIV clinics, and has also been a member of the Swedish Médecins Sans Frontières board for several years. Since her return to Lebanon in 2008, Dr. Farah has been involved in the founding of the LAU School of Medicine, working mainly on the microbiology and infectious disease curricula. She has also been an attending physician in infectious diseases at LAU Medical Center Risk Hospital from 2011 to 2022. And since October 1st, 2022, Dr. Farah is the coordinator of the Middle East Medical Unit and antimicrobial referent at Doctors Without Borders in Beirut. Thank you, Dr. Farah. One of you might have to mute their mic. Yeah.
Okay.
سامعينكم.
So
one of you needs to unmute. So either Crystal or Dr. Farah.
are you hearing me now?
Yes, now it's perfect. Yep.
Okay, great. Because we're sitting just one beside each other, Crystal and I. Thank you for that. Very long introduction.
Yeah, of course. And we can't see your screen, by the way, if you have slides.
Yeah, sure. So thank you. First of all, I want to say thank you very much for inviting us. Thank you for the very long introduction. And Dr. Sabatin, we would love to hear more from what is happening inside. It's really very, very interesting. We are sitting in Beirut, so we're close by, outside. And what I'm going to talk about is more general about how, because we're a unit that works mainly on antimicrobial resistance. And I was going to talk a little bit about how Médecins Sans Frontières does it in settings that are not very comfortable. So what challenges do we have? We have war, of course, destruction, refugee, crowdedness, just like Dr. Sabatine was describing, problems with diagnostics, all these files that you see that are often gone and disrupted, medication that can be difficult to access. So we work in these kinds of settings and conditions. So how do we tackle that? We have developed a kind of system where we work to tackle this. And we usually, it's not rocket science. I think this is how most of the people tackle antimicrobial resistance. It's really based on 3 pillars that are infection prevention and control and antimicrobial stewardship. And when we usually focus on starting first with the infection prevention and control wherever we come. And then as a second part comes the stewardship. Microbiology being really, a cornerstone in doing stewardship and improving IPC, we also help out with installing microbiology. We also do learning, health promotion, so we have other activities that are transversal all along. Now, as you see in here, we have the basic package when we have IPC and stewardship, and then we have the full package when microbiology come along. Microbiology without stewardship is really not recommended and has shown to do almost more harm than good. So really we have IPC and stewardship that is really well grounded before we start with the microbiology. Where do we work? You see here, we're a little spread out all over the world, wherever it is needed. The stewardship committees, usually we have a clear action plan. We have something called reference. So we have a steward in place and reference, which are seated a little bit like me. I'm a reference, so I would give advice and follow up my focal point that is in the field. We use different strategies depending on what kind of project we support. So it might be, of course, we do audit, quantitative, qualitative, but the access to antimicrobials is both restrictive and mainly restrictive, but also we have some proactive. We usually have guidelines that are for all MSF projects, but that we tailor for each particular setting and for each country. So this is how we work with our reference. So we have our happy hour where we give feedback, but we also give feedback on a continual basis. We collaborate with the Ministry of Health. Sometimes we do our own hospital, but very often we work within a Ministry of Health setting and we collaborate. Infection prevention and control, again, not rocket science, hand hygiene, cleaning, disinfection, etc. We use a very specific tool to measure, which is simplified, that can be easily put up in the field and easily followed. And this is a way of scoring our project and scoring how we are doing in IPC. Water and sanitation, we help out with that, of course, too, which is a centerpiece that Dr. Sabatine said, really a centerpiece for hygiene. Now, our infection prevention and control stewards and our antimicrobial stewards, we train them. So we have an academy that is internal to MSF, and you see here we have people from all over the world that participate in that. And that is really, I think, one of the positive things that we leave behind is training people. What about the microbiology labs? In many settings, there is no microbiology labs available, and sometimes there are, but the quality can be variable. So what we do, if there are a microbiology lab, is that we assess them. If there's a local microbiology lab that is of good quality, then we would work with them. If not, we can help them improve quality. We can help them with consumables. We can help them with trainings. We can help them with personnel. And if there is no microbiology lab, there is something that's called the mini lab, the MSF mini lab. It's basically boxes. You see here 6 boxes that come and that are mounted up. So you see here, and with this you can do some basic, usually we start with blood cultures and then CSF cultures, and then comes the more complicated cultures like urine, but it's usually limited to that. But it can be a great help when you need to be quick and you need to put up something. So fast is a little bit, you see here, it still takes time to do the trainings, and it takes 4 to 6 months to really have it flowing smoothly. What we also have in the microbiology to help out is an app, Antibiogo. So the Antibiogo app is a phone-based app where basically you can take a photo of your disk diffusion test, and it will help you interpret. It will help you interpret your plate and tell you if your pathogen is resistant, sensitive, or not. It's semi-automated and gives has a very efficient. This way you don't have to have very skilled personnel. You can go with simpler trainings. Health promotion is something we do also in all our projects whenever we are in the field. How to use antimicrobials, how to deal with them. Operational research. What's operational research? It's really voicing out and seeing what can be used, what cannot be used. In these particular settings. So it's research that is tailor-made for our settings and where we learn from them. So whatever we research on, we actually try to use in the field, or it's voicing to push an agenda forward. So I'm going to say thank you for me, but before I leave, I would, if it's okay, if we have time, Noor, is a video about AMR that our team in Gaza did last year for the World Antimicrobial Awareness Week. That was that was a few days ago, finished last week. So I don't know, Crystal, if it's okay, if we have time, Noor, if we can share that.
Yeah, please. Yeah, go ahead. Yeah. We can't hear it. Could you possibly send me the link and I will show it after Crystal's talk?
Yeah.
Okay.
Yeah. Thank you so much, Dr. Farah. And I want to point out to how important it is to voice out and to publish, because that's the way I actually was able to get in touch with Crystal and Dr. Farah through their recent publication about antimicrobial resistance in Gaza. And so as a segue, Crystal Musalli is an epidemiology advisor working with the International Medical Humanitarian Organization Médecins Sans Frontières. She's also part of the Middle East Medical Unit, an MSF unit based in Lebanon, and focusing on the topic of antimicrobial resistance. Drawing from a wide experience over a decade with MSF, Crystal has been dedicated to supporting humanitarian work since 2011, with a particular focus over the past few years on the MENA region. Her expertise in her field expands over a spectrum of public health issues, including sexual reproductive health, non-communicable diseases, and trauma. However, her main research interest has been around antimicrobial resistance in the Middle East, and one of her most recent publications highlights the challenges of AMR in the context of the Gaza war. Thank you, Crystal.
I just want to make sure that you guys can hear me. Yeah?
Yes, we can.
Yeah?
Yep.
Perfect. So thank you, Noor, and thank you for the organizers, basically, for the invitation and for giving us an opportunity really to highlight how conflict can affect health in general, taking the antimicrobial resistance here, talking specifically about Gaza. Just before starting, I wanted before starting to talk basically about the impact of war on antimicrobial resistance, I wanted to start by giving you a broad picture about the type of pathogens, if you want, and the type of resistance that we actually see in our MSF-supported projects in Gaza. So we have reconstructive surgical projects where we support the Ministry of Health in 2 hospitals in Gaza, Al-Nasser Hospital and Al-Auda Hospital. Those projects basically started after or following the Great March of Return, which is, for those of you who don't know what that is, they're basically demonstrations that were done by the population in Gaza between March 2018 and December 2019, where basically they were denouncing the siege that Dr. Sabatine talked about since 2007, basically the blockade imposed by Israel on Gaza. So this Great March of Return, basically demonstration, resulted in a high load of injured and overloaded and already fragile health system because of the siege. Many of those basically injuries were very complex to deal with, and due to different factors, basically, if the wounds are not well treated, they can lead to infections and can also lead to amputation. So most of the patients that we've seen since we started supporting this project in May 2018 were infections to the bones or osteomyelitis. What complicated those infections is that basically more than half of them were polymicrobial, so were caused by more than one pathogen at the same time. Both of them potentially being able to be, that could be multi-drug resistant organisms. Around 30% of those infections were recurrent. So basically, some patients we would keep on seeing for months and for years, they keep on coming back with repeated infection. And around 70% of those infections were due to multi-drug resistant organisms. So just to mention few, the most prevalent was Staphylococcus aureus, and around 65% of them were methicillin resistant. We've seen Pseudomonas aeruginosa, 35% of them resistant to ceftazidime and imipenem, and most, if not all, of our Enterobacteriaceae had some type of resistance, including carbapenem resistance. So this is just to give you like a nutshell of basically the complexity of dealing with the wounds, because they are multi-drug resistant, infected by multi-drug resistant organism. So this is the baseline we're starting from. Now, during war, again, what happened? If you want to go back to those 3 pillars that were mentioned by Dr. Anna, for us to be able actually to diagnose those infections, to know what are those types of pathogen and the resistant pattern, we need the infrastructure behind this, right? So we need functioning microbiological labs. We need the trained people who are able to get bone samples, analyze them, interpret the results, and communicate them, so that the doctors basically that are taking care of the patients are able to implement antimicrobial stewardship. So they are able to provide the right antibiotic to the right infection and so on. What we're seeing in Gaza today is actually healthcare facilities being directly targeted. So microbiological lab can be totally destroyed. If I want to talk about the MSF-supported lab in Al-Auda Hospital, a week ago, it was only partially functioning because of the lack of electricity and power. Unfortunately, you're seeing in front of you the picture of 2 of our MSF doctors that we have lost to this war a couple of days ago in Al-Auda Hospital. We have also lost one of our laboratory technicians working in a microbiology lab at the beginning of the war. So and it takes a lot of time to build capacities, to train people so that they become confident and they can like even when we leave, in terms of like organizations that are able to sustain and continue without our presence. So this is what the war actually is doing. But even if it's the diagnostic capacity is totally reduced, but even if it's there, as Dr. Sabatine was mentioning, the availability of antibiotics might not be there. So we might not have the luxury, basically, to have the correct antibiotic to appropriately treat the infection. So just to give an example, even before the war in Gaza and due to the siege, there is a study that was done in 3 different hospitals in Gaza that showed that key essential medications were the availability of key essential medications were as low as 45% at the time of the survey. So even before the war, we're talking about, essential medications that are continuously in shortage due to the siege. So we can only imagine now during the war, and I'm putting here the picture of the Rafah border because whoever of you is following must know that even the aid that is coming in today is very, very slow, and it really doesn't cover the needs. So this means that your antimicrobial stewardship basically programs are broken, to say the least. And what it also means is that most often, basically, the healthcare team will be using broad spectrum antibiotics as empirical therapy for war wounds, leading to selection for highly resistant organisms, and providing as well those broad spectrum antibiotics to treat multi-drug resistant infections contribute to antimicrobial resistance and increase the risk of hospital-acquired infections. And what I want to add to this is drawing from the picture that Dr. Sabatin showed us about the state of the hospitals that are still functioning today in Gaza. They are receiving casualties way over their capacity. So we're talking about hospitals that sometimes they're receiving 500 casualties or war wounded when they have 100 beds. So you don't have the capacity in terms of human resources to deal with all of this. So you have your people a bit lying everywhere, but it also means that you have to rely on the people that you have, like the medical team that you have, and surgeons who are not trained in war surgery, they can have hard time basically to properly debride the wound. This is from one end, but also with the a high number of casualties that they are receiving and the war wounds that are receiving, it means also that they might not have the time to have those patients in the operating theater as much as they want. It also means that they want to stabilize the patient and then, go to another one. So the follow-up is not properly done as well, which again means that the wound might not heal properly, which would increase the risk of infection. And going from, again, a baseline of multi-drug resistant organisms available, it also means transmission of antimicrobial resistant infection. Adding to this, of course, infection prevention and control measures. So again, there is almost no way to, Dr. Sabatin, you've said it really very well. There is no way, even with the best of intention, to really have put in place or implement infection prevention and control measures. So this as well adds to, fueling the transmission of infections between patients and caregivers, and also into the community, because you talked as well about the sewage, the sewage system. So they're not working properly in hospitals, right? Because there is no fuel, there is no electricity. So for the pumps to basically for the water to be cleaned before it gets out of the hospitals. And again, from what we know from Gaza, even before the war, is from studies that were done there. So a study showed, for example, that 35% of water and surface samples that were taken out of hospitals from Gaza had a high bacterial contamination and also high levels of resistant bacteria. So today, with this water, basically dirty water going out of the hospital without being properly treated, then all of this is going into the community. And sewage is flooding the streets, so it's like a free environment for bacteria as well to be moving around. The last one that I would like to mention as well, that we often maybe forget, but we have a lot of documentation that is coming out about this, is the impact of the environmental pollution of war on antimicrobial resistance. So we have more literature that is showing that heavy metals that are actually come out of the destruction of the infrastructure, but also from the type of weaponry that is used, actually play a role in triggering antimicrobial resistance. So what we are seeing is basically bacteria that is evolving resistance mechanisms to combat heavy metal toxicity through the encoding of resistance genes to heavy metals, but also to antibiotics, and this means that they can be transmitted. Basically, those resistance genes can be transmitted even between different organisms. It can also induce selective pressure on pathogens, leading to antimicrobial resistance. So if I want to add with one thing, I would also say that during war, surveillance systems are like totally loose, and they're potentially even not functioning. So we don't have the capacity today to monitor and track any emergence of new resistance, for example, to antibiotic that is happening in Gaza, which means that if you don't detect early, it means that you cannot implement measures to actually prevent from a spread of those resistance when they emerge. This is again something that the war basically totally destroy. So again, yeah, it becomes like very hard to count any death or complications due to antimicrobial resistance, but it is definitely happening. So what I want to leave you with is that also to keep in mind that all of this, even if it's happening in Gaza, it doesn't mean that the rest of the world is protected from it. So when we talk about antimicrobial resistance and we talk about transmission of infections and transmission of genes, resistant genes of for instance, like any other disease, those can cross borders. So we also have to take into account that there is a global health security threat that as well come out of this. And I'll end here. Thank you.
Thank you so much. Thank you all for your insight. I'm going to show the video quickly and then move to the Q&A portion with one of our attending physicians, Dr. Alisa Khan. I'm going to give you the mic while I show the video.
Oh, perfect. Okay. Hi, everyone. My name is Alisa Khan. I'm a pediatric hospitalist at Boston Children's and one of the faculty at the medical school. And I am a researcher in health equity. And here is our video.
Have you ever heard about antimicrobial resistance? Antimicrobial resistance is when a germ that causes illness or infection, like a bacteria, stops responding to the medication that's designed to kill it. In recent years, the overprescription and misuse of antibiotics is causing them to become less powerful, which is why we see antibiotic resistance happening more frequently. In MSF, we are trying to tackle antimicrobial resistance on a daily basis. Let's see how. So let's start at the hospital here in Gaza, where MSF has a reconstructive surgery project. When a patient is suspected to have an infection in the bone, they will be seen first by the orthopedic doctor and antibiotic doctor, who will supervise their management plan, which could include taking a bone sample. This bone sample will be taken by the surgeons in the operation theater under the supervision of an infection prevention and control team. Then, the sample will be transferred to be tested in the lab by the microbiology team. Here, we will determine the organism causing the infection and what antibiotic it will respond to. After that, the antibiotic doctor, after receiving the results, will start prescribing the appropriate antibiotic treatment and make sure it's effective. Finally, an important part of our rule is health promotion. We want to raise awareness among our patients and the community so we can prevent antibiotic resistance from growing through overprescriptions or misuse. We do this through different means, like patient education, community activities, as well as using social media to reach the population and answer the related questions.
I wanted to thank Ms. Musali and Dr. Sabatin and Dr. Farah for really excellent presentations and open it up to Q&A. So if there are any questions, I have a whole bunch of questions, but I will save them so others have a chance to ask first for any of the speakers. Questions, comments?
I'll ask one. Somebody asked Dr. Sabatin if he could comment more on the WHO's latest statement that says that the WHO declared that infectious diseases might cause more deaths than bombs in Gaza. Sorry, Dr. Sabatin, did you hear that? Do you want me to repeat it?
Yeah, please repeat it. I didn't hear.
Yeah. Someone is asking if you could comment more on the WHO's latest statement. So the WHO declared that infectious diseases are going to cause more deaths than bombs in Gaza.
You know, the situation is complicated, and the surveillance issue they are also complicated now. But if I understand the question well, I think the infection also will do a lot of death there. Yeah, I agree with that, with the sequences of war and the attacks in the people and sequences of complication, especially with multi-drug resistant sepsis and septic shock, and loss of a lot of functioning will do their bad sequences and results. So we have a lot of deaths directly related to the attacks, and also there will be a lot of deaths related most probably due to multi-drug resistant. And we saw a lot of multi-drug resistant before the war, and now the environment is just healthy for microorganisms, let's say, which is, I think, wrong to use this language, but this is the suitable situation for multi-drug resistant to grow and to spread and to cause serious invasive infections as a sequence of septic shock and death. Yes. Did I answer the question?
So thank you, Dr. Sabatin. Are there other questions in the chat?
There's one, I guess, repeated question. We had it last time, and it's about. We have a question that has been asked before, but perhaps it would be a different answer coming from an epidemiologist and infectious disease specialist. But what is the moral and ethical duty of epidemiologists around the world and infectious disease specialists now to prevent any further damage?
Well, I mean, if I may, I don't know if really, I don't know if at this stage it's about splitting between different, you know, like skilled people to try to do something. I think when it comes to Gaza, what we're seeing in Gaza, what we need to be doing ethically is to raise our voice and raise awareness about what's happening, like all of us, you know, like at the same level, independently of who we are and what's our background. Because what is needed today is actually for the war to stop, for the ceasefire that we're seeing now to become permanent, because this is only when you can start basically rebuilding. Now like putting my epidemiology hat, I can say what I can say is that you know, thinking about the rebuild that hopefully we're gonna start witnessing soon, is to try and focus on, you know, like surveillance system again, because this is how you will be able to monitor, to early track any outbreak that will potentially start. Maybe they're starting already now, but again, we're just not being able to detect them right, and to implement measures to prevent their transmissions and so on. But really at this stage, I think yeah, this is my very personal opinion, but to try and voice out basically what's happening, the impact of this war on the population health and public health in Gaza, at the same level, like yeah, independently of who we are.
As an infectious disease, I think very much of the first help is really the basics. You know, you have to start with the basics: hygiene kits, water, structures where people can live. Prevention is the first thing to do. The number one thing, even in infectious diseases, is hygiene. Also, we have to prepare ourselves for what's going to come. The infected wounds, the infected burns, putting up our guidelines, knowing what we have helps a lot, meaning that knowing what antimicrobial resistance was there before the war already gives an idea about what's going to come after. So surveillance systems that are already in place helps a lot in what we're going to come afterwards. But again, number one thing to do is ceasefire so we can stop.
Thank you all for that answer. Any other questions
Can I just
comments? Oh,
sorry,
yes, please,
I would
Dr.
like to say
please.
some words here also. It's very important. Yeah. Thank you. You know, I just want to emphasize one thing, that the health system in Gaza now is out of work, completely out of work. They have nothing to treat their chronic patients, almost nothing. There are no drugs, there's no medications. They're doing anesthesia without operation without anesthesia. And I think the world, they are just watching and just looking to them, and there will be a lot of damage, and because there is no health system in Gaza now. So there is no water. We are discussing a lot of things while there is no basic issues there. There is no water, there is no sanitation. They are not.
Hopefully Dr. Sabatine can be reconnected, but I think that's such a important point that beyond just sort of thinking about multi-drug resistance, even just the simple things of like, when we saw the list of infections, there are things that are really preventable and that are treatable with simple things like hydration. Please, Dr. Sabatine, please continue.
Yeah, I don't know if you heard me or not, but there are no water.
We did.
There is no medication. There's no health system at all. So I think everything, any step that we will take will help people. But the things that I would like to emphasize, that myself, I was asked several times to do to talk about in the local media about the potential infectious disease in Gaza, and I refused to do that. But I accepted to do that with you because this is these learning things, and we have to talk about that also for the people to hear what the situation there. But I refuse to do that locally because for me it's not comfortable to talk about the infection prevention measures, and they don't have water, they don't have medications, they don't have and antibiotics. So you know, it's difficult. It's not easy for me at least to talk about this point and to ask people take a prevention measures while they are hungry. They have no food, they have no water, and I'm asking them to take themselves to take care of themselves. So everything will help, anything will help, but they have nothing.
Dr. Sabatine, that is such a sobering reminder of, it just puts everything in really deep contrast and real deep context about, we can talk about all these high level things, but at the end of the day, if you don't have food and water and electricity and so you know, how are you going to prevent, how are you going to heal? I think that's a really good reminder. Dr. Sabatine, you're on the ground. How can we hear, what can we do to support besides raising awareness about what's happening and about the lack of these basic necessities and the need for a more sustained ceasefire and peace? What can we do in our locus of control as medical students and providers?
You know, at this level, at this point, I don't think, sorry to say that, but I don't think we're able to do anything. because from their side, from Gaza side, they have no internet, there is no electricity to do even with them through Zoom or something education. They don't have basic issues. The most important things now is to stop war and to start increase help with this through the Rafah معبر.
The crossing.
Yeah, yes, thank you. So because nothing entering to Gaza, almost nothing. You know, they sent to Gaza for the last days kits for testing for COVID. Do you can imagine test for COVID nowadays? I don't know. People, they are hungry. They are dying from the pain. There's no water. So need to increase all these helps from the from the Rafah cross point, and we at all, even in West Bank in Palestine, we have nothing to do because we cannot go to help our colleague there. We can't do. They prevent us to do that, and they don't allow us to do that. So I don't know exactly what we can do. Just we can dua for them.
To pray.
I'm so sorry to say that. Yeah, but this is.
I mean, Dr. Sabatin, you're right, but I think, I mean, again, because it's so hard to feel very powerless, really, in front of what we're seeing, because we are, as individuals, we definitely are. But I mean, again, the small hope, and I really know from where you're coming, but what we're also hearing from people inside Gaza, that they feel that they are not heard. They feel that whatever is happening inside is not, like being it's going to the outside world. So I think having you guys like medical students in the US probably again, I don't want to generalize, but make sure that you actually get more awareness about what's happening, expose yourself to what's happening. Don't be biased to like one side of the media, because we know that the Western media is trying to convey as well like potentially, I don't know, like a different picture than what we are seeing in our part of the world. So I think educate yourself about what's happening and try to be vocal as medical students. If you come together because you understand, when you see what does it mean to be without water and without fuel and electricity, what is the impact of this on the healthcare of the population, I think your voice can have a different weight than like the rest of the world. So at least
That's
try
right.
to do that. Yeah, because this pressure could maybe change something, maybe.
And already this event that you organized had made quite some noise for you in Beirut.
Yeah.
I think it's a good reminder about praying, but then also trying to use our voice in the spaces we are to learn and to advocate. Other questions or comments from the group? Oh, please.
Can you hear me? Yeah, thank you very much. My name is Abdurrahman. I'm a medical professional as well. I just wonder, thinking about the long term after this aggression ends, hopefully soon, what do you think can be done in order to improve the healthcare system in Palestine in general and in Gaza in particular? It seems like there is severe deficiency in healthcare providers, specialists. Is that because the medical education does not have the capacity to produce good number of medical students, or is it because there is basically no specialty training? Do your students able to travel to have higher education and specialization? Do you think it's more reasonable for specialists to come to your area in order to provide some training? What do you think is the best way in order to help the healthcare system to strive and improve?
The question for me, yeah, there's a lot to do. I think we have a problem with, let's say, but between us, okay, the system that we have in Palestine, it's not so good that can help in developing ourselves as physicians and also the student. We have medical students, we have medical schools, and they are enough around us. But the system as itself, the system, there is a problem with it. And, you know, if you want to do a develop yourself, depend on yourself. There is no track that you can take it and reach to the step that you develop yourself with this system. For example, I would like to take the infectious disease issues and the multi-drug resistance. We don't have in the governmental hospitals a system for surveillance for the we don't know how much we have the CREs, the Acinetobacter baumannii. They are not doing that in the West Bank at least, and Gaza. So we don't have the system. I think that's the problem. But the capacity, the physicians, we have it, but we don't have a good system. I think the most important and the danger that now from the health system, from the health in the Palestine, is the multi-drug resistant and their spread. So I myself focusing a lot on this point. We worked with a lot of hospitals, and also these three branches were mentioned by our panels after me. I mean the diagnostic laboratory and the infection prevention control and antimicrobial stewardship. We worked a lot and trying to improve the way that we are working with our patients, but still we are away from what we wanted to reach. So I think the problem again with system, and we have all talked to the Minister of Health, the policy makers, to change and to put the system that can develop the system as whole.
Can I add to this? Because I think, I mean, you highlight the specialization of, I mean, the training, basically, the lack of opportunities of trainings for people in Gaza. I think, and I don't know if it's maybe important for the audience as well, like we talked about the blockade that Gaza is under for years and years now. So medical professionals, they don't get always the luxury basically to travel and specialize and come back, you know, like the way many of you maybe, you know, like probably are not from the US, but are now there and they're studying, and maybe they will spend their life there, they'll go back home, and, you know, so the siege means that the movements of people in Gaza is controlled by Israel. So even as MSF, if I want to give an example, when we want our teams to go out of Gaza to have trainings, where it's a stressful game, because we're waiting to hear back if they got their visa, if actually they were allowed to go out of Gaza, and so on. So it's really basically it's really not easy. So to go back to the question, if I understand it well, and again, if and hopefully soon the war will stop, and then rebuilding what can be rebuilt from the healthcare system that is today like totally destroyed in Gaza. I hope that we will have, you know, like international attention, international aid that will go there. We at least know that few organizations will be there, you know, ICRC, MSF. I don't want to, many organizations will potentially be there. If you get the chance to go and volunteer, you know, like as medics in Gaza, what I would advise and what I would recommend is take a mentoring and a coaching approach when you do that. Try to rebuild or build the skills of the people. Try to give a bit of your experience so that when you leave, all of this is sustained there. And again, I don't know, Dr. Sabatin, what you think, but I think it's also very important for those organizations as well to try and involve the local authority, the Ministry of Health, in the rebuilding, so that it gets sustained. So instead of thinking of, like field hospital that will be important at the beginning, but they come with their equipments and their people, think about, like rebuilding basically, or improving the functionalities of hospitals that are today like partly functioning. So I think this is where the focus should be. Strengthen what is available, try to build what is not functioning today, and hope that the siege will be lifted one day so that Gaza can become independent as
Dr. Sabatin, can I ask a question? Is it
What's yeah. I don't hear you.
I'm muted, sorry. No.
So are you hearing me now?
Okay.
From
Yeah,
the
yeah.
national,
Yes.
I wanted to ask if before October 7, how was the surveillance? How many hospitals were linked to a surveillance system like HUNET, etc.?
AMR surveillance
AMR
systems.
surveillance system, because you're very vocal about the
Yeah.
AMR.
Are you asking Gaza specifically, or
Yes.
particularly on the Palestine?
Gaza.
Gaza.
Mm-hmm.
I think there is a poor system of surveillance there. The national surveillance for the AMR is not going there.
Okay.
Also in the West Bank also. So,
Okay.
but for example, we are doing that in Augusta Victoria Hospital, and we are receiving a lot of patients from Gaza. We receive a lot of patients from other West Bank cities, and we have an idea about the multi-drug resistant moving from area to area and something like that.
Yeah. I mean, we could see from our data that they're already, almost 80% of the Staph aureus seem to be MRS safe. This is for the last 2 years, noting that it is osteomyelitis only. Yeah. So yes.
Yeah, difficult to treat serious infection.
Okay, thank you.
Yeah.
I think we're coming to the end of our time, so we really wanted to thank Ms. Musali and Dr. Sabatin and Dr. Farah again for lending your time and your expertise and your experience and having us all learn from it. And we thank you again. There is a QR code with some evaluations. If people could fill those out so that we can get feedback. And anything else you want to wrap up to say?
There's a QR code for feedback, and there's a QR code for listserv if you want to stay in touch so that I could send you the updates. And thank you very much. Thank you to our speakers. Thank you so much.
Thank you guys.
Thank you.